Eh bien, bonjour tout le monde. Je vous propose qu'on commence. Merci d'être présent. Merci aux personnes en ligne aussi. Si vous entendez pas, faites-nous signe. Normalement, ça doit bien marcher en ligne. Donc, on est très heureux aujourd'hui d'accueillir Nigel Rollins. Je parle en français parce que Nigel comprend le français et je pense que là, il y a majoritairement des personnes francophones, si ça vous va. Tout le monde parle français, hein, on est d'accord? Donc, du coup, euh, Nigel Rollins est avec nous dans le cadre, en fait, du programme de visiting professeur de l'Université de Bordeaux. Et donc, il va travailler avec nous pendant plusieurs mois. On a prévu plein d'activités et parmi ça, des cycles de conférences. Et donc, voilà la première aujourd'hui. Et je vous introduis juste. Nigel, on se connaît depuis très longtemps avec Nigel. Ça fait une vingtaine d'années qu'on travaille ensemble. Nigel est pédiatre de formation. Il a ensuite longtemps travaillé en Afrique du Sud sur des problématiques de santé materno-infantile. Et puis ensuite, il était au département de l'OMS qui s'occupe aussi de la mère et de l'enfant. Et il est maintenant retraité de l'OMS et professeur en santé globale et santé de la mère et de l'enfant à l'université Queen's University Belfast. Voilà. Et donc, ben, Nigel, on est très honoré que tu sois là. Vraiment, merci. The floor is yours.
Thank you. Désolé, je ne vais pas parler en français. You will understand if I try to speak in French, you will understand why I'm speaking in English. It's a real pleasure. I was saying to Rodolphe, I have enjoyed visiting Bordeaux for the past 15 years, maybe more. And when I was working at WHO, it was a great escape to come from WHO and Geneva to Bordeaux and to just a different world. So thank you for the chance to share with you today. I'm from Ireland, so I hope you can understand my accent. If there's anything, you'll need to speak to your neighbour to understand. Just a little bit about myself, my past medical history. Is that I trained in Belfast. I did my doctoral research in Tanzania on vitamin A and iodine deficiency. I then went to work in South Africa. I arrived 1 month after the elections in 1994 in Durban, and suddenly my world was changed from living in Belfast to living in Durban and HIV. Everything was HIV. It was not just health. I worked in the state hospital looking after children with diarrhea and malnutrition and the ward. Everything was just HIV. But socially and politically, everything was HIV as well. So it was a complete immersion from what I was used to. And then I became involved a little bit more with research. This is where I met Renaud a long time ago. Because of that experience, not Renaud, but with Renaud, I was then asked to join WHO, and I moved there in 2008. And I was there for about 16 years, and I finished last year. And today I am delighted to both have a position in Belfast, but also to be visiting here. So thank you. What I want to do is to reflect a little bit on 40 years of HIV. I haven't been involved with HIV for 40 years, but close on 30. And to think a little bit about what we learned from all of that. Some of our mistakes, what are some of our challenges, and really looking forward to what it means. And I was speaking with Irina just a little bit earlier, and this seminar, this session is about HIV, but it's not about HIV. It is about how we approach public health. It is how we use evidence, how we are aware of context. It's aware of everything that is changing around us to develop public health policies that improve the lives of the people that we're living with. That is our job. That is our responsibility. And we need a way of improving those approaches. So that's what I hope we will try to cover today. This is the front page of the Lancet 30 years ago, or 40 years ago in 1985. And you'll see on it, this was the first report of HIV, a new disease in Uganda and its association with what was then HTLV3. Slim's disease. But in the very same edition in October 1985, we see on the right-hand side that HIV virus was identified in breast milk exactly the same time as the first clinical reports. What happened after that, and this is important for setting context, is that the UN Secretary General, he referred to HIV in its totality and AIDS as the greatest catastrophe on the planet at that time. He was anticipating not just the health, but the social consequences of HIV. And remember that analogy of being the greatest catastrophe, because recently we have lived through another crisis in the context of COVID. This was a slow burning catastrophe, whereas what we experienced with COVID was a much more rapid timeline, but there are similarities. Ironically, with infant feeding, because people realized the potential and that HIV possibly would be transmitted through breastfeeding, and because of the importance of breastfeeding for child survival, people were saying this was the quote of someone who was very senior in UNICEF at that time. He said, "Will it be the death of breastfeeding?" And people, this was from the Wall Street Journal, they painted the baby manufacturers, Nestle and others, as being the saviors of African children. This was no more than 13 years after all of the boycotts of Nestle in Africa, because they were introducing formula and marketing to women and families in formula, and that caused millions of children to die. And yet within 15 years of that knowledge, the formula companies were being identified as saviors. This was the very first statement from WHO in 1987. And it was a simple one-page document. And it said, breastfeeding, breast milk, and human immunodeficiency virus. And there it says, in individual situations where the mother is considered to be HIV infected, consideration should be given to the socioeconomic, ecological environment of the mother-child dyad and the extent to which alternatives can safely and effectively be given. I think it was actually a very reasonable statement. But actually, if you think what was said in 1987, and I'll show you in a few minutes, the WHO recommendation in 2000, 13 years later, it's almost identical to this. And what we will learn is that it was almost impossible to implement. Almost impossible to implement. So over that next 12 years until 2000, we did learn. And I'm just going to take little bits here and there to illustrate the journey. This was in the year 2000, there were two really big publications. The first was, and I think it remains, the only randomized trial ever where women were randomized to either breastfeed or to give formula milk. It's the only randomized trial ever of breastfeeding and formula feeding. So this was in the absence of any antiretrovirals, because there were no antiretrovirals for HIV transmission. And this was conducted in Nairobi. And it's a very interesting study. Now, if we had time to discuss this, I would say there's several really big methodological problems here, or that the results point to some really big methodological questions. First of all, it was randomized. And yet you see that the transmission rate at birth was double in the population of mothers and infants who were randomized to formula feeding or to breastfeeding. So the populations cannot have been equivalent right at the beginning of that. And that's just a chance finding. It wasn't anything orchestrated or deliberate. It was just a failure of randomization. The second thing is that at 6 weeks, you see the difference even more, because transmission is measured generally about 6 weeks after taking a blood sample. And the impact of infant feeding should not really be seen at 6 weeks. And yet you see the double transmission rate here is also being seen at the transmission rate at about 6 weeks, reflecting in utero and peripartum transmission. But what you see after that again is that from this time onwards through to 24 months, on this line, that the children that were randomized to formula feeding, who were counseled, who were given free formula milk, who had electricity, who had running water, there was continued transmission. And that can only mean one thing: they weren't exclusively giving formula milk. So in a randomized trial with all the support and counseling available, these women, and the data came out later, between 30 and 40% were still breastfeeding, even though they were being given free formula milk, etc., etc. And you can maybe say, well, maybe the counseling wasn't very good, or maybe the interpretation is that within that cultural setting, it was just too difficult to give formula milk. This was a study published by Anna Koutsoudis in Durban, same year. This was actually a vitamin A trial. This is entirely observational. But the bottom line is that you see that at birth, there are 3 different groups here. And basically they were the same at birth. There was a little bit of difference at 6 weeks. This is exactly the same group. These are the mothers and infants who are breastfed. It's what we would call mixed feeding. Almost identical numbers to here. In this sort of purple color, it's exactly the same. These were the women who said that they were exclusively formula feeding. And in fact, it's much flatter than here. And this is probably because they were only giving formula milk. And then there was this other group in the orange, and these were the women who were exclusively breastfeeding. And what you see is that certainly through to 12 months, there was no statistical difference between these 2 groups. And it was suggesting, it wasn't proof, that somehow exclusive breastfeeding was protective against transmission in the first 12 months of life. But it was only a suggestion because this was observational data. And so the body of knowledge at that time allowed us to say these couple of things. First of all, in 2000, we were able to say that between 5 and 7% of children become infected in utero. Around about another 10 or 15% get infected at the time of labor and delivery. And then, depending on the duration of breastfeeding, between another 5 and 20%, the longer you breastfeed, the greater the proportion, become infected out to 24 months. But if you add up the numbers, we still see that the majority of children born to a woman with HIV, 2/3, would never become infected. And yet for many people, it felt that it was inevitable that if the mother had HIV, if she breastfed, all of her children would become infected. There was this belief, and that was communicated within communities. Again, this is 2000. there was this WHO publication saying, in general, this had nothing to do with HIV. It was saying, what is the protective effect of breastfeeding on all of child survival? And you can see that there is a huge effect within the first 6 months. These are odds ratios. Odds ratio, I think it was, yeah, these were odds ratios. And you can see that protection, it was 6 times reduced mortality in the first 2 months, nearly 3-fold reduction in mortality in the first 6 months, specifically against diarrhea, 6-fold, remember this number, 2-fold reduction in mortality for pneumonia-related mortality. And this was the evidence base from the observational trials, the randomized trials, and the meta-analysis that happened then whenever WHO met to make a recommendation in 2000. And if you think about the recommendation in 1987, it's not very different from this. When replacement feeding is acceptable, feasible, affordable, sustainable, and safe, avoid all breastfeeding, but otherwise exclusively breastfeed. The AFASS became very famous in the HIV world, called AFAS. It went on to say something very important, however, because it then talked about the implementation of this. It said that HIV-infected women should be given specific guidance in selecting the option most likely to be suitable for their situation. But this makes 2 big assumptions. One is that health workers, first of all, communicate the right information accurately. So just think about what we hear about vaccines and measles and the fake news and what that does to public health confidence and the uptake of vaccines that we saw during COVID, during measles. There was a lot of fake news there, and there was a lot of misunderstanding at this time. But critically, it also assumes that a woman, even if she has the accurate information, can actually do what she wants to do. And many times that simply wasn't true. So what happened between 2000 and 2010, 10 years? Well, first of all, we had a study in 2006 being published, Jerry Kuvadia, and we see that the suspicion about exclusive breastfeeding was confirmed. We see that breastfeeding, breast milk and formula milk had about a 2-fold increased transmission risk compared to exclusive breastfeeding. Whenever breastfeeding was given and solids were given the first 6 months, there was almost a 10-fold increase in transmission risk. This work was also done in Zimbabwe, the Jitambo trial, Peter Iliff and Jean Humphrey, Peter who subsequently died, sadly. But these were big studies, 4,500 mothers, almost 3,000 infants, and they found that with exclusive breastfeeding, the transmission risk was about half of what you had with mixed breastfeeding. So half, 2-fold increase. So it was very consistent. What we also had at that time was data about the mortality. So now we're not talking only about transmission, we're talking about mortality. People hoped, well, maybe if you give mothers all the information, maybe, unlike the randomized trial in Nairobi, maybe they will adhere to formula feeding and we will not have the same mortality. But this is exactly the same study in Nairobi, and you see that in the children randomized to formula, the excess mortality associated with formula. So that was in a randomized trial, the best case scenario. And then there were many studies from Uganda, Kenya, Zambia, all showed exactly the same thing. 6-fold more increased mortality risk in children who were born to mothers with HIV, but who were formula fed. So even in the context of large programs support, you had this large excess in mortality with no real benefit in terms of transmission. So we've got to say, well, what was happening in the health system? Why was this happening? And this was a study, a small study in South Africa. So South Africa at that time had one PMTCT protocol. It followed the counselling guidance from WHO. So health workers were supposed to counsel people according to their circumstance. Same training, same protocol. Rietvlei is a rural area in KwaZulu-Natal, Eastern Province. And you see in Rietvlei, a rural area, the vast majority of women were formula feeding. The Church of Scotland clinic in rural KwaZulu-Natal, the vast majority of women were breastfeeding. So what was happening here? This was not a randomized trial, this was observational. And this was clearly that the health workers had a certain belief, and the way in which they talked to women completely changed the infant feeding practice. In Rietvlei, everybody believed in formula feeding. In Church of Scotland, everybody believed in breastfeeding. And so you saw the influence of the health worker. So I was involved in a small study, 4 different countries, and we went and talked with nurses and counsellors in 4 countries. And we asked them some questions, but this was one question we asked. If 100 mothers living with HIV breastfeed their children, how many of their children do you think will have HIV? The vast majority, 40% of the nurses said between 80 and 100% of the children will become infected. 13%, 26%, another quarter said between about half, they believed that about half children will become infected. And only 8% of the nurses and counsellors interviewed got the right answer. So only a small number of the nurses and counsellors had accurate information themselves, so that when they were talking with mothers, they were actually communicating the right information. So it just made that recommendation from WHO almost impossible. It just was never translated into practice. In the same 10-year period, in addition to confirming exclusive breastfeeding, learning about counselling, we started having observational trials about the impact of antiretrovirals. DREAM, Mitra Plus, Amati, KIBS, doesn't matter where they're from, but they were reporting transmission risks less than 1%. You had Mabana study, which was a bit of a complex study being conducted in Botswana, and they were reporting, this was a randomized trial, different regimes, but again, very low transmission risks associated with high viral suppression because of the antiretrovirals. And then you had Keshobora, conducted in 3 countries, Kenya, Burkina Faso, and South Africa, and you see in a randomized trial, very significant differences in transmission risk during the course of breastfeeding. And that takes us now to 2010, when the next guideline meeting occurred, and you now had high quality evidence that antiretroviral interventions, both to infants or the mothers, really significantly reduced transmission. There was no evidence of significant drug-related adverse events, and there was a significant, you knew the other side of the story, that whenever women were giving formula to their children, that there was increased morbidity and mortality. And that took us to the guideline meeting in WHO. And there was guidelines all happening on testing, on antiretrovirals in pregnancy and infant feeding. It was all a coordinated process. And this was the recommendation on infant feeding. There's a couple of interesting things. It's the only WHO recommendation that I know where the recommendation is directed not at individuals, not at health professionals, but at the governments. National health authorities should decide whether health services should principally counsel and support to either breastfeed and receive antiretrovirals or avoid. And the decision of the health authorities should be based on consideration of the population. This is the public health approach. The health authorities should make a decision. They should look at everything, the mortality rates, the nature of the health systems, the type of mortality in their country, and they make a blanket decision for all of the health services. So in fact, France was following this WHO recommendation, even though it didn't realize it, because here in France, people would have been recommended to avoid all breastfeeding. Because if you think about the local epidemiology, the risks for survival, it makes sense. But it doesn't make sense in Zambia or Zimbabwe. The other thing about this is that it presents the outcome as being HIV-free survival. It was not HIV prevention. It was the total story of prevention and survival. And if you're a parent, I don't want my child to avoid HIV and then die from diarrhea or malnutrition. I want both. In English, we say, you want your cake and to eat it. Okay, you want everything for your child. And in fact, you want more than survival because you want development as well. In that guideline, it then went on to say, breastfeed for 12 months, because that's the maximum benefit in terms of survival, okay? One of the most interesting things I found in that guideline, and what really made a big difference, and this was actually presented by a lawyer, and so really he was a human rights lawyer. I think from a public health perspective, this is a really interesting concept. It was the idea that the nature of counseling changes depending on the quality of evidence. Okay, let's think about that. When you have a situation when the balance of risk, this is not about HIV, this is anything. When you have the balance of risk between options is unclear, in research we will call that equipoise. The only ethical thing that we can do is to say to the parent, you cannot say do this or do that because we don't really know. You can only say these are the risks. Your child might die from diarrhea and malnutrition, but your child might die from HIV. It's an impossible situation, but that's the only ethical situation. As the evidence changes and you start having evidence about effective interventions that are cost beneficial, then it changes, because now the health worker can be much more confident to actually present a single option and to say, we think that this is the best option for you. If I have cancer and I go to see the doctor, they may say to me, well, you can have radiotherapy, chemotherapy, radiotherapy and chemotherapy. You can go to the Alps and you can get high altitude clean air. You can have multivitamins, all of those things. I said, I don't want to hear any of that. I want to hear what's best. Tell me, what should I do? I want to know their opinion on that. I don't want to hear, in fact, all the options. I want to get to a single option because of the quality of evidence. And then you have the extreme end of this continuum, where some people may actually present a risk to the public. If someone has schizophrenia, they're a danger to themselves, they're a danger to other people. At that situation, you don't have agreement on the intervention. That person is taken and they're given. And this is what actually happened in South Africa with extremely drug-resistant TB, XDR TB, and people were actually taken from their home and forced to live in certain communities in order to assure TB treatment. But there were many problems, even in 2000, even with the excitement about antiretrovirals, because people said, and there were debates on stages like this, for you people living in the high resource countries, or people in high resource countries were saying, it is unethical. You are applying different ethical standards for people living in Africa and people living in Europe. They said, if formula milk is the right approach in France, then formula milk must be the right approach in Rwanda, Zimbabwe, Kenya, wherever. And this was a major, the community was completely torn apart. It was a really, really tough time scientifically and socially. But it also then raised questions, is it justifiable to have these public health responses, blanket approaches to say, in this country, we will promote one option only? And then mothers were asking, do I really need to stop breastfeeding at 12 months? Can I not just carry on if I'm getting the drugs? Since 2000, things have changed more again. We have learned more clearly about HIV transmission. Some of it is what we call cell-associated. Some of it is cell-free. And that's actually a really important point I'll mention why in a moment. And we have found, well, this is actually the consequence, is that unlike transmission between adults, where if you have 0 virus detected, that is what people call undetectable, that means untransmissible. U equals U. So for adults, if you are not able to detect, you cannot transmit. And that has become a big advocacy and communication strategy. Undetectable equals untransmissible, U equals U. But that is not true for breastfeeding. And one of the problems is we still don't know how HIV is transmitted to children, because you need to get into the gut at the time. You need to be in the intestine to see exactly. We have many theories. It can happen anywhere from the tonsils and the pharynx down through the gut. It can happen through the virus can squeeze down in through to get to the lamina propria. It can infect the lymphoid tissue in the gut. We still don't truly know. What we do know, however, is that transmission risk, the largest group in the light blue, are the women who did not receive antiretroviral treatment during pregnancy or breastfeeding. The biggest risk for breastfeeding transmission is not receiving treatment. But we have also learned that about 30% of the children who become infected through breastfeeding, it's because the mother becomes infected herself when she is breastfeeding. It's what we call incident transmission. Very hard to get to. But it means that everything in terms of our public health response has got to be about prevention of infection to mothers. So when you combine this red, this is the incident infection, with those who don't get transmission, breastfeed or transmission in these groups means that this accounts for more than 50% of all transmission. And that's our challenge for the future. So can we reduce even less than 1% transmission risk. Can we get that lower? And so there's a lot of work going on about active immunization, passive immunization with broadly neutralizing antibodies, costs potentially of less than $5 per dose. That would protect the child entirely. So this is where the science is going. But while that science is happening, there are other things we still need to attend to. There is still a research agenda. How do we improve retention in care? It's good enough if we can get women started on antiretrovirals, but starting is not good enough. It is to create the system so they remain on antiretrovirals consistently through life. It'll protect the woman's health and it'll protect the child. How do we reduce gender inequity? Enable women to make decisions and choices that they want for themselves. If we are not dealing with this issue of equity, we cannot get to the bottom of the problem. And this has brought the thing full circle in high income settings, because there were women who wanted to breastfeed, even to take antiretrovirals, but they were scared because there were situations whenever women started to breastfeed and the children were removed from them in France, in Belgium, in the United Kingdom. The European AIDS Clinical Society in 2018 said, in case a woman insists, like I must breastfeed, then, well, maybe we will give you some support. It has changed. And in 2023, this is the undetectable equals untransmissible, which is not true for HIV, but basically both in Europe and in the US and in WHO, the guidelines are now permitting. They're saying, let's talk about this. Because the efficacy of the antiretrovirals is so good that do you remember the continuum of counseling? We are somewhere down here in high resource settings. It is a legitimate and fair discussion. So, looking back, and it's always easy when we look backwards. I don't know, in French, I don't know the word for hindsight. Hindsight is when you're looking behind you. We had, the evidence was drip, drip, drip. We had small pieces of evidence each year, and that made it very difficult. We had real difficulty contextualizing HIV and mortality and low resource settings, both globally and within countries. There were very, very strong positions. People argued the priority is to prevent transmission. Other people said we need to think about prevention and survival. The two communities were not together. Women were often forgotten about. Often it was just the mother, we need to prevent transmission to the child. And then we often forgot that there was mortality due to HIV, but we forgot about other mortality. I was in one meeting and I had a major attack. They said, we cannot have one child becoming infected with HIV. And the attack was, it doesn't matter if children die of diarrhea, but they must not become infected. And then there was this recognition that breastfeeding is a lot more than nutrition. It's more than child survival. It's a social symbol, and it is emblematic of both good motherhood and good care in many cultures. What do I think looking forward? Well, I think it's important about the framing. It would have been so much better if the entire community were agreed that we need to achieve HIV-free survival, not just prevention of HIV. We should have put mothers and infants on the same level. and to recognize that the mother and child, the newborn, cannot be separated. We need to understand the impact of gender equity and empowerment in everything from prevention of the mother becoming infected and of the child. We need to recognize that the health workers are the gatekeepers of knowledge, and we need to support them. They can help or they can create a block. And community engagement and communication is critical, first of all, to build understanding, to avoid false messages, reduce stigma, and to get buy-in for any intervention. Have we learned? The most recent global crisis in health, mothers and babies being separated in France. Global guidelines not agreeing. The US and China CDC saying avoid all breastfeeding. WHO says we need more evidence. Laboratory scientists identifying fragments of RNA, a laboratory scientist identifying only a fragment of SARS-CoV-2 virus in the discussion of their publication saying breastfeeding should stop. Where was the public health response? What we need for going forward is to understand public health approaches for deciding policy, whether it be for COVID or any crisis or any context. And we need to have that recognition that takes in context and setting. We need commitment to evidence. We need coherence between organizations and agencies. I absolutely love this picture. It was by a guy called Yanni Jordan, a master printer in South Africa, and it's called Birthright. And you see that the mother and baby are inseparable. They're highly vulnerable in this very small boat on this sea. This guy, he was actually a pathologist. He was talking about carcinogens. He said, throughout life, we seem to swim in a sea of problems. Problems is my changing of carcinogens. And it's only by good management and planning that we escape. It's possible to plan. It's possible to take on public health responses. So realizing that birthright for health for all women and children, it will not happen on its own, but it's something that we can pursue, and in our own academic and research and personal lives, we can fight for that. Thank you very much.